Okay.
Awesome. Well, thank you so much, Sean, for that introduction. And welcome, everyone. Thanks for spending your evening with me. I am just going to pull up my presentation here. I will be saying everything that is on the slides, but if for some reason you have any questions, of course, we have a Q&A session at the end that we can always discuss at length, whatever you guys want to talk about. So the topic, as was already mentioned for tonight, is age-related macular degeneration, which is abbreviated as AMD. Um, just a brief overview of the anatomy of the eye. If you look on the left here, this is a cross section of the eye. With the front surface here is the cornea, which is the window into the eye, that is the surface of the eye that you see. Behind that is the iris, the pigmented part of your eye, which is either brown, blue, green, as we all know. Then you pass through the lens that becomes a cataract. And then all the way in the back of the eye is the retina. The retina is like a wallpaper of nerves that covers the entire back of the eye. It basically, the light comes to the retina, and the retina processes that information and sends that signal of light to your brain via the optic nerve. So this is a high resolution photo of a very small part of the retina, which is called the macula. The macula is the very center part of the retina, and it's where your 20/20 vision comes from. If there's issues with your macula, that vision could be distorted or deteriorated, such as in AMD. So the three major causes of blindness in the United States are number one is age-related macular degeneration, and it's the number one cause of blindness in patients greater than 60 years old. Glaucoma is the number one cause of blindness in our African American population. And diabetic retinopathy is the number one cause of blindness for patients less than 60 years old. And unfortunately, number three is gaining. So macular degeneration is characterized by loss of central vision. If you think back to that photo I just showed you, that macula is right in the center of the eye, and it processes your fine vision, which you use for your central vision. It's often asymmetric and unequal, but it happens in both eyes. If you have macular degeneration in one eye, you will have it in the other. It's extremely uncommon to have it in just one eye. And it typically progresses really slowly, where it presents for the first time, in your 50s or 60s on the earlier stages, and progresses as you age, hence the name age-related. There are certain types of macular degeneration. One of them is the wet type, and that can cause rapid loss of vision. The hard part about this is it's painless, and there's not a lot of things that people who develop macular degeneration did to put themselves at risk. A lot of this is related to genes and just family history. There is some association with smoking, though. So if we look at this picture of this young girl, the top left is a normal photo, albeit a little bit blurry. Macular degeneration can cause a lot of issues, including distortion in the center. Do you notice how the bricks off to the side still are not that distorted, but right in the center, there's some distortion. It can blur the center of the vision or cause what we call scotomas, which are complete blackout of a small area of the vision. Within macular degeneration, there are two types. The more common type is called dry age-related macular degeneration. The less common type is the wet macular degeneration. And within the dry type, there is in a very advanced stage of dry macular degeneration called geographic atrophy, and we'll be discussing all of these. So first things first is, how do you know if you have age-related macular degeneration? And like I said, it's an asymptomatic disease unless it's in very advanced stages. So really, the American Academy of Ophthalmology recommends general eye screenings every 2 years from the ages of 40 to 65, not just looking for AMD, but also looking for glaucoma, cataracts, diabetic retinopathy, all of these things that start developing in your middle-aged years. And then once you reach the age of 65 or older, it's typically advised that you be seeing an eye doctor at least every year, more if needed. A type of image called an OCT, or an optical coherent tomography, is especially helpful in diagnosing AMD, as it shows any abnormalities in the retina. So these are photos of that macula again. Here is your regular optic nerve. This person's healthy blood vessels that's providing oxygen to the eye. And this whole area in red is the retina. But this is only a very small area here called the macula. If you look at the photo to the left, this is an example of what dry age-related macular degeneration is. You can see these yellow deposits that actually are underneath the retina that give this yellowed appearance. These are deposits that are called drusen. It's basically a mix of calcium and lipid deposits, or fatty deposits, that build up underneath the retina from slowing metabolism in the eye. And remember, as I said, this is both an aging process, but heavily genetically associated, meaning that just because not all elderly patients will develop these deposits called drusen, you also have to have the genetics that put you at risk for development of dry AMD. This is an image of an OCT that we discussed before. Your general eye doctor, when they see those findings, those little yellow findings on your exam, may get one of these. The picture down below is a normal image of an OCT through the macula. A normal macula has this nice U shape to it. And you can see all of the layers of the retina like a layered cake. These are all different layers of nerves in the back of the eye that each serve a specific function. This is a very healthy looking eye. Now, above, you can see this patient has a U. Their U is a little bit smaller, but that can be normal. And you can follow these inner layers of the retina, and they still look nice and normal. However, this bright white line out here, you can see has this lumpy, bumpy appearance, almost like it's pushing up on the retina. And those are those deposits from a slowdown of the metabolism in the eye that we call drusen. And when you have drusen like this, it means that you have dry age-related macular degeneration. So dry macular degeneration can most of the time actually not have symptoms. But in more advanced stages, it can lead to distortion and blurring. Now, how do we reduce your risks of developing macular degeneration, and also reduce the risk of your macular degeneration progressing once you do develop it? The number one thing that we cannot stress the most is stopping smoking. Even secondhand smoke from a partner who lives in your home can put you at higher risk for progression. These patients have 3 times the increased risk of developing vision loss from age-related macular degeneration than their counterparts. Not to mention, of course, the other benefits of smoking cessation. Other things that can reduce your risk is by maintaining a healthy diet. Leafy green vegetables are excellent for your eyes, and specifically for age-related macular degeneration. Any vegetable that is high in folate. So we talk about kale, we talk about spinach. All of that is beneficial for the eye. Blood pressure and cholesterol have been linked to the progression of AMD, as well as for some people, UV light exposure, so wearing sunglasses outside. And again, I cannot stress the importance of routine screening, especially if you have family history of either the dry or the wet type. Dry age-related macular degeneration is typically monitored with clinic visits with your doctor, somewhere between every 6 to 12 months, depending on severity and depending on how quickly the disease is changing in your eye. When I see a new patient with age-related macular degeneration, I usually start them on average at a follow-up of 6 months for a year. And if that at that year to year and a half time point, you look pretty stable, I may start shifting you out to maybe 8 to 9 months and then eventually get you on a once-a-year cycle if as long as you are monitoring at home. And what exactly does monitoring at home mean? There are a few ways you can monitor at home, but the most common way is something called an Amsler grid. This grid helps you focus on only the center of your vision and looks for distortion. Now, the way you use this chart, normal is to the left, is you look at this center black dot with one eye at a time. It is very important that you look with only one eye at a time with your glasses on, because your other eye will cause if you're having an issue in one eye and the other eye is working well, you won't be able to discern the difference unless you're checking one eye at a time. And on the Amsler grid, if you're seeing blackout areas or areas of distortion where these lines look wavy or the lines look like they're pushing in or pulling out towards you, that is concerning for possible age-related macular degeneration. I usually tell my patients just keep a copy of these grids on, in a cupboard that you open a lot or on your refrigerator so that when you think about it, at least like 2-3 times a week, you see it and you just do a quick check one eye at a time to look at that center area to look for any new distortion as a good reminder. The other thing, I'm going to come back to this, is that unfortunately there's really no effective treatment to reverse dry macular degeneration, age-related macular degeneration, and there's nothing that we can do to reverse vision loss in dry AMD. There are multivitamins that you have probably seen advertised on the news that do reduce the risk of progression of dry macular degeneration to the wet type, which we will discuss in a bit, by about 25%, which is pretty good for multivitamins, okay? These multivitamins are only recommended for people to use if you already have macular degeneration. It unfortunately didn't show that it was preventative for developing it, but once you have it, it does slow down the progression. And these multivitamins are called the AREDS 2 multivitamins. Some of the common brands that you may have heard of are Preservision, Focus, and Ocuvite. There's a ton of different brands, and you can get them at any pharmacy. Costco has them and sells them at the most affordable price. But you take them twice a day and it does reduce the progression and risk of turning to wet macular degeneration. Now, there are also a ton of other eye vitamins out there, but the AREDS 2 formula, AREDS 2 formula, is the only one that was studied by the NIH and proven to actually slow the progression of macular degeneration. I'm sure many of the other eye vitamins out there may have good components that are not bad for your body. However, this formula specifically is the only one that was proven to really slow this risk. So when my patients come in taking other eye vitamins, I strongly recommend them to switch to this. Thankfully, macular degeneration for many people, they really don't need treatment and it only requires routine monitoring. But over time, there may be newer treatments that come here and there. Now, there is a subset of age-related dry macular degeneration called geographic atrophy. And this is when those areas of drusen, those lumpy, bumpy areas, kind of merge together and become a big scar. This is responsible to about 1/5 of the blindness from macular degeneration. We always harp on the wet type of macular degeneration, but geographic atrophy can also cause blindness, and this is also permanent and irreversible. Um, in this OCT image here, you can see how the nerves are nice and thick here, and then all of a sudden they drop off, and there's no nerve tissue there. Unfortunately, the retina is like brain tissue and nerve tissue, and science hasn't gotten to the point where we can bring it back yet. So if this happens, you are permanently blind. Prior to last year, there was no treatments available for geographic atrophy. And this has been a really great year for retina in general and eye health in general, in that the FDA approved 2 treatments that slow the progression of dry macular, age-related macular degeneration for patients who have geographic atrophy, to prevent this from taking out their central vision. Now, of course, these drugs are extremely new. And they only slow its progression. They don't stop it, and they require frequent injections. So they are only good for patients on a case-by-case basis, but it is a good sign that there are new therapies coming out. And it's a very exciting time, with the hope that we can prevent this 10 to 20% of legal blindness out there. So I had already harped on the AREDS2 multivitamins. These are the components of the multivitamins. And again, the easy way to know which ones are correct is just look for AREDS2 on the bottle. And you will know that that means that is what the NIH studied, that formulation of these 6 items. As you can tell, actually a lot of these do not overlap with a general multivitamin, but talk to your doctor or your primary care doctor to see if you already are on a regular multivitamin, if you need to switch things up. Again, the main brand that you hear a lot is PreserVision, but there's also Ocuvite, Focus, MacuHealth, and MacuGuard. For patients who are affected with the geographic atrophy and have vision loss, there are a ton of low vision devices out there, and low vision specialists in the DC, Maryland, and Virginia area. The POB, Prevention of Blindness Society, is a great resource to help tell you where to go to at least be evaluated for these things. So I highly suggest, if this is something you're interested in, reaching out to us so we can refer you to a low vision specialist. Okay, now we are going to move on to wet age-related macular degeneration. Wet age-related macular degeneration is when bad blood vessels grow from underneath the retina, like weeds growing through a concrete, like here. And those bad blood vessels grow into the retina, and they break and they bleed, and they can cause and wreak a lot of havoc on your nerve tissue. It looks like this on exam. So you can see these little patchy white spots. Those are where this patient's drusen, and there's more underneath. But this patient unfortunately developed bad blood vessels that burst and bled into their retina and caused them to lose vision. About 10 to 15% of patients with the dry type of macular degeneration over their lifetime will progress to the wet type of macular degeneration. And this can happen slowly with early distortion, or it can be sudden and cause a very large bleed. And it's very hard to know who would fall into which category. On those pictures, this is an image of a patient up at the top with dry age-related macular degeneration. As a reminder, these lumpy, bumpy areas were those drusen. And unfortunately, this is the same person a few months later who developed bad blood vessels. And in this area of black, that's actually all blood underneath their retina. And you can see those bumps have grown as well. And this person, sometime between when this photo was taken and this photo was taken, developed wet macular degeneration. When your doctor is concerned for this change, they may get a test called a fluorescein angiography. This is a dye test that looks at circulation in the back of the eye, but also identifies if there are any bad blood vessels growing. Okay. Typical fluorescein angiography would have white going through your blood vessels. Okay. But there really shouldn't be any white anywhere else. And this patient, as we follow it over time, this is earlier and this is later as the blood flows through the eye, you can see this big white spot because there's actually blood leaking out of those abnormal blood vessels. So thankfully, we do have treatments for wet age-related macular degeneration that work really, really well as long as it's caught early. These medicines target a molecule called vascular endothelial growth factor. Okay. The treatment for this was actually found in this type of medicine is a type of chemotherapy drug. And it was found that people who were getting a drug called Avastin, this chemotherapy drug, for their colon cancer, were having improvement in their macular degeneration. And somebody had the bright idea to convert this to an eye drug when they saw this response. And it's really changed the amount we can treat patients and prevented a lot of blindness. There are tons of different anti-VEGF drugs, and these drugs are all administered in the office via eye injections. Many of you on this call may already experience or be getting eye injections. We use these injections for age-related macular degeneration, strokes in the eye, diabetes in the eye. So these medicines have now been used for a lot of things. And there are a lot of different brands. 4 of the most common ones are Avastin, Lucentis, Eylea, and Vabysmo. We typically use whichever drug your insurance prefers for the time. And then if you're not responding, we switch to other medicines. But they are all anti-VEGF drugs. So they're all in the same class of drugs. And the goal of these medicines is to get rid of those abnormal weed-like blood vessels that are growing in the retina and keep them from bleeding and causing you vision loss. So when anyone gets this as a new diagnosis and we tell them that they're going to need injections in the eye, their, of course, initial reaction is not a pleasant one. No one's happy about hearing this. But as crazy as it sounds, we've gotten pretty good at doing this. As a retina specialist, I do, more than a dozen of these every single day, as do all of my partners. The way we do this is we numb the eye with anesthetic, and then we use an antiseptic solution to prevent infection, and then we do the injection. As crazy as it sounds, they most of the time do not hurt. And we can do things if you're having pain to really prevent you from having issues with these injections. It's definitely a process to get used to. I often tell my patients, there will be a point where you're accustomed to the injections, but at the end of the day, it's never completely a normal experience to have to come in to do treatments. But again, these are vision-saving treatments, and we do everything in our power to try and make it as comfortable as possible for you. And these drugs work. So this is an older type of OCT. It's just green instead of the gray that we've seen. This patient had bleeding underneath their retina, as you can see with this black here. And all of this bright green is some of those bad blood vessels. And they got 1 injection actually a handful of injections, a series of injections over 6 months, and their eye returned to almost normal. You could barely even tell that they had had an issue before. Now, and these injections, again, have helped save vision in millions of people. But the hardest part about them is that this is a treatment and not a cure. When you were diagnosed with age-related macular degeneration, and it's the wet type, you initially require these injections monthly until we can get rid of any blood that could possibly be there. And then we typically start treating you a little bit less over time, maybe week by week, to where you go from like 4 weeks to 5 or 6 weeks, and then 6 weeks to 7 or 8 weeks over time, as long as your disease is under control. Many people, if not most people, need treatment somewhere between every 1 to 3 months. I feel like most of my patients are somewhere around the 6 to 8 week mark. Okay. And unfortunately, these drugs don't last in the eye. So I often see patients who stop getting injections and miss a few appointments, and they have vision loss. Again, it's a treatment, but not a cure. This is just another image just showing how these injections work. So these are some blood vessels, and this patient got one injection. And at 1 week, you can see how those blood vessels are kind of shriveling up here on the side. But then those blood vessels are coming back at 4 weeks. So that person needs another injection to keep their disease at bay. Now, the newer agents are really aimed at decreasing the amount of injections you need over time. Not only is it a burden on you to get these injections every month to even have to do them, but also coming into the doctor once a month is a tough ask. And we definitely understand that, and as do pharmaceutical companies. So they are trying to get longer acting medicines. A lot of you may have heard of a drug called Vabysmo that they've been advertising quite a bit. Some of these drugs go out to 3 to 4 months, excuse me, between injections for a lucky subset of patients. But again, there's a lot of patients, even on those drugs that were shown to maybe require less injections over time, who still need monthly injections. We still don't have a wonder drug that completely eliminates the need for these injections. And long term, we're hoping that they may come up with some kind of gene therapy that would reduce the amount of treatments, or extended release drugs, like an implant that you can put in the eye that would stay in the eye so that you don't have to keep coming in every month for treatment. So that is the end of my talk. I wanted to give plenty of time for questions. And I'm just going to put this here. I work at the Retina Group of Washington, so I'm a medical and surgical retina specialist. And I see patients in our Rockville and Silver Spring locations, and you're more than welcome to take down these numbers if you are interested in evaluation.
All right. Thank you so much, Dr. Mathai. This was absolutely incredible. I know I learned a lot. So for those of you who have questions now, just a little housekeeping. If you have specific questions about your specific condition, Dr. Mathai may not be able to answer everything because she doesn't have your records right in front of her. However, she can answer a lot of general questions as well as anything related to macular degeneration. For those of you who would like to ask a question, there is a Q&A box at the bottom of your screen. It's about it's probably maybe the second or third one from the left. Additionally, if you would like to voice your question, you can raise your hand. And again, the option to raise your hand is under more, and there's an option, it's the fifth or sixth one down, called raise hand. Once that happens, I will give you the opportunity to talk. All right, so I do see a couple of questions popping up in the Q&A. I'm going to give that 1 second while people do that. I do see we have Thomas Little. I'm going to give you the opportunity to talk and ask your question. Thomas, you just need to unmute yourself.
Can you hear me?
Yes, sir. Go right ahead.
Okay. Um, Doctor, I wanted to ask whether dry eye, or what, if any, impact does dry eye have on macular degeneration?
That's a great question. So, dry eye is dryness of the surface of the eye, so the outside of the eye, that causes burning and irritation. So, there is no direct relation between dryness of the eyes and macular degeneration. However, if you have dry eyes of your own, you've probably realized that when your eyes are very dry, your vision becomes blurry. And if you already have distortion and vision problems from macular degeneration, having dry eye is only going to make that worse. So, just like anything else, we try and optimize all medical problems in the eye at the same time. We don't just focus on one thing. So, treating dryness of the eyes when you have macular degeneration may help improve your vision and optimize your vision over time.
Okay. Could I ask one other question?
Of course.
All right. I I've considered taking AREDS too, and I've looked at the package inserts, and they indicate that one of the components, I think it's vitamin E, is way, way above the 100% a daily recommended amount, and that at levels even higher than what's in that formula uh, indicates that one side effect is possible brain bleeds. Are there any side effects associated with taking AREDS too, because of the high components of some of the ingredients?
So so AREDS 2 particularly has high levels of vitamin E. Your body only absorbs a certain amount. I'm sure you've heard this about general multivitamins. So you don't absorb the full 300, 400% of the daily dose that they have put out there. At very high doses of vitamin E, especially for people on blood thinners, it has increased the risk of bleeding, which is why they put that on the package. But it's not all that common with AREDS 2 multivitamins. Now, if there's a patient of mine who's had multiple bleeds in the past, I may talk about this risk, but otherwise, for the vast majority of patients, it's not really a concern. I would always want to double check any medicine that you are on, especially if you're already taking a multivitamin, to see the levels, not just only of vitamin E, but also vitamin C, zinc, to make sure you're not taking more than the necessary amount. But you will notice if you look at pretty much any multivitamin package of any sort, the amount that's in there is much more than 100%. And unfortunately, that's just because taking pills, all of it doesn't get absorbed. So to get the amount that your body needs, they often have to up that amount in the actual pill.
Okay. Thank you, doctor.
Of course.
Okay, we did have a question in the Q&A. It's a little bit of a statement, but I think we can build off of it. Somebody said that with their injections of Eylea, they experienced burning, but with Avastin, they only felt pressure. So I guess the question is, are people going to have different experiences with the different medications?
So first of all, everyone's eyes are different. So your experience getting injections is most likely going to be different than your friend or your family member who's getting injections. And every doctor has their different techniques, and some people may respond better to certain techniques versus others. As far as your burning with one medicine versus the other, it's not the most common, but it can happen. Any reaction to any type of medicine, as it can happen like that. Typically, burning after the injections is actually not from the injected drug itself. It's from the antiseptic solution that we use. It's called betadine. That betadine is very irritating. It's almost like a soap for the eye. It's unfortunately necessary to decrease the risk of infection. And when we use it, it decreases the risk of infection by more than 100 times. But it does cause a lot of irritation because it causes very bad dryness of the eye. If you imagine getting shampoo in your eye, it's almost that same feeling. So people do experience some significant burning after these injections if they have pre-existing dry eye. If you were to come to me for injections, what I do is I try and pre-treat your eye with some artificial tears, and then every doctor rinses that betadine out vigorously with the hope that you don't have any irritation. And then we tell our patients to use lots of artificial tears, dry eye treatments immediately after the injection and for the rest of that day to help with the irritation. If you're somebody who is very sensitive to that betadine, we can use an eye patch after the end of the procedure that keeps your eye closed for a few hours. When your eye is closed, it's constantly being lubricated by your own natural tears, and that can be helpful as well. So there are definitely ways that we can reduce the burning. But as far as different experiences with different medicines, everybody's eyes are different.
Thank you. We did, and we have another question. This is a little bit of a two-parter. They said that their mother has AMD, but the dry kind, nothing's really helped her. Is this still the case with the dry AMD? I believe you mentioned a little bit about that. And then additionally, they added on, so should I be taking these AREDS vitamins preventatively if I don't have any symptoms yet?
So if your mother had the dry type of age-related macular degeneration, and she did not have what's called geographic atrophy, then really just taking AREDS is the only treatment out there to reduce the risk of development of the wet type. Now, there is a subset of dry age-related macular degeneration where you develop that thing called geographic atrophy, which is the scarring. And as of last year, we now have the first treatments for that. Again, these treatments are not perfect. They just slow the progression of that dry type, that geographic atrophy. But there are some newer medications on the market that can be helpful in those cases. And you would need to see a retina specialist for that to discuss if you would be a good candidate for that. Now, as far as taking the AREDS2 multivitamins, nothing in that formulation is particularly harmful, but those studies from the NIH that looked at 35,000, 40,000 eyes showed that people who took macular degeneration, those AREDS2 multivitamins before they had macular degeneration, it really didn't slow the progression or decrease their risk of developing macular degeneration. So we only recommend it once you already have the dry type of AMD.
Okay. And here we have a couple research questions, Dr. Mathai. Where is the focus of the major research being done on AMD?
Sure. So there is not one area. So vision is important to everyone, and there are a lot of things that are in trials or even much more before a clinical trial that are like the National Institute of Health and other places are looking at. One of them is, longer, newer medicines that treat wet macular degeneration for a longer period of time. There are constantly new medicines coming out for the geographic atrophy over time. Okay, and those are all very, very new and decrease the risk of blindness. And there are some thoughts about gene therapies. The problem is there's more than one gene that puts you at risk for age-related macular degeneration, but all of that is in really good research, but nothing, unfortunately, yet in the gene therapy sector.
Okay. Let's see here. Folks, if you do have questions, please feel free to continue putting them in the chat box. Another AREDS question. They were prescribed the original AREDS formula. Should they switch to the AREDS 2, or is there a major difference?
So the original AREDS formula also was shown to decrease the risk of progression to wet macular degeneration. However, they found that especially in people who had previously smoked that type of medicine, there was an ingredient called beta carotene, and that was found to be linked with lung cancer. And so that was taken out of the formulation and switched with medicines called lutein and xanthine over like 15 years ago now. And typically, I just recommend everyone use AREDS 2 formula over the AREDS formula. It streamlines it, makes it a little bit easier for me, but also just as a decreased risk. There was no real link between people who had never smoked before and that lung cancer, but in my opinion, if the other formulation has never had any link with cancer, I prefer my patients to take that one.
That makes sense. Okay, so this individual has wet AMD and they received the shots. They have not had any blood detected for over 2 years, so it sounds like they're having a positive experience overall. But how often should they see their doctor?
So that's a great question. It depends on your eye. Like I said, we can never cure age-related macular degeneration. We can just treat and maintain. So when you come in with bleeding, when you first present, my number one goal is doing injections every month until I see no more bleeding, okay? Because that means we are controlling the disease in your eye. After that, we slowly start decreasing the interval of those medicines because that means they're lasting in your eye for longer. And I go week by week because it's that delicate of a procedure, to where I do not want you to have a big bleed. And rarely, if ever, do you ever get to stop that medicine. Some people may be the lucky ones that can get it every 4 months or so, and there may be a few people that are able to get off of it for their lifetime, but it's extremely uncommon. Most patients need injections somewhere between 6 weeks and 3 months every 6 weeks to 3 months to prevent bleeding from coming back in their eye. So it's a patient by patient thing. I'm not sure about your eye, but I would recommend that you follow their instructions on timing, but it would be unusual for any retina specialist to space you out further than 3 to 4 months because of the risk of having a large bleed when that medicine wears out of your eye. And once you develop a large bleed, that could cause permanent vision loss that we cannot bring back.
Mm. And thinking about the monitoring side, is there any research being done towards any at-home screening equipment that would be able to do imaging at home so that way they could then send it to you so they don't have to necessarily come in? Because we know many of your patients would probably be seniors and transportation could be an issue.
Yes, there are newer at-home monitoring things for both dry and wet macular degeneration. The dry type is actually available right now. It's made by a company called Nodal Vision, and if it's something you're interested in, you should talk to your doctor. Even general non-retina doctors can prescribe this for you. It's an at-home device that essentially has an Amsler grid within it, and it processes how you're seeing the same picture every day. And if there's a computer kind of recognizes that. And if there's any data point that looks different than you had seen it the last few days, it sends it to the doctor and gives them an alert that, hey, something's going on and you should probably be brought in. And that same company is actually developing an ability to have at-home OCT monitoring, those pictures that we looked at earlier today, for people who have wet age-related macular degeneration. But it is not available to the public just yet, but probably in the next few years.
Wonderful. Susan Dweck, go ahead. You have a question?
Yes, I've had age-related macular, the wet kind, for 10 years. Been having injections at different intervals, as you said, for 10 years. Recently, friends who were just diagnosed have told me after the injection, they're advised to do a lot of things differently, like not wash their face, not get the eye wet. Would you just talk about those a little bit? Because that's not something I was ever told. I don't
Sure.
think it made a difference, but it was something I was never told.
Sure. So all of these are very, the main things I tell my patients is the day of, try not to get water in the eye, just because we're not sure tap water is all that clean. And, no swimming, no going hot tubbing for that day. But after that, I say you can go back to your normal activities. Of course, our main goal here is just avoiding an infection in the eye. The injection, the size of the needle we use is so very small, smaller than even insulin needles. But we don't want an infection, so we just try and do everything we can to prevent it. The main thing for you to help comfort after the injection is, instead of putting water directly into the eye, we would recommend using preservative-free artificial tears to lubricate your eye. Now, you can still wash your face, just keep your eyes closed so water doesn't get directly into the eye. Same with showering. Those are all things you can do as normal. Just keep your eyes closed in the shower so water doesn't get directly into the eye for the day of the treatment.
Thank you.
Okay, and let's see here. This is a drug-related question. Their doctor wants them to begin Syfovir for dry AMD. What is that?
So Syfovre is one of the two medicines that over the last year the FDA approved for the geographic atrophy type of dry age-related macular degeneration. Okay. And again, these medicines are very new, but it's the first treatment that can actually slow the progression of that scarring that can happen in very advanced stages of dry age-related macular degeneration. Geographic atrophy is permanent and causes black spots in your vision and can eventually progress to completely lead to blindness. And that happens to about 10 to 15% of people with macular degeneration as a whole. So these newer medicines, including Syfovre, have shown to at least slow the process of that scarring, with the hope that you maintain good vision for longer. But just like our other drugs, nothing is perfect. They require injections on a monthly to every 2-month interval. And it decreases the growth rate by about 20%. So it doesn't even stop it. But again, this is the first medicine. These are the first medicines of its kind, and even decreasing by 20% could give you an extra couple of years of vision when you think about it. So some people do find that worthwhile. As far as whether or not you should start it, again, it's dependent on how and what the state of your geographic atrophy is, and if it has been expanding and progressing over the last year.
All right, and we do have time, folks, for another question or two. Jewel, I see your hands raised. Do you have a question?
Yes, I do. I've tried to take the AREDs for, a month or more, and after a couple weeks, I started having very intense pain in my stomach in the mornings, and then I developed some vomiting. And do you know of other patients having that kind of problem? I do have gastritis and that kind of stuff.
Right. So I do have a few patients who've had stomach issues with any multivitamin. Same thing, because that pill has to be broken down. So especially if you already have stomach issues like ulcers or gastritis or reflux, that may be something that you're bothered by. The first thing I recommend to my patients is try and taking that with food instead of just taking it with their pills in the morning, and see if that helps.
I
If that
always
doesn't
did. I
help,
always did take it with food.
good. If that doesn't help, there are chewable formulations that you can take that start that breakdown process in your mouth instead of in your stomach, so that it doesn't affect your stomach as much. And I've actually found that that works really well for people. The Preservision brand makes a chewable form of it that you can get on Amazon. And that's worth a trial. You could even try other, so some of them are tablets versus some of them are those liquid capsules. And the liquid capsules may be easier in your stomach as well. And then lastly, if none of those work, I would talk to your doctor, but I've at least suggested maybe trying to get one pill instead of 2 pills a day. But that would be my last resort because that means you're underdosed compared to what the treatment trials recommended. But see if you can tolerate that. And of course, if that doesn't work, I mean, that's definitely a case-by-case basis, but I would talk to your doctor. But we wouldn't want you to be vomiting by any means for a multivitamin. And
And I'm
at that point, I would be optimizing, no smoking, avoiding secondhand smoke, using UV protection, and eating those leafy green vegetables.
okay, thank you. I am a person who hadn't vomited for like 40 years.
Yeah.
So
Yeah, and that's no fun. I
it,
cannot imagine that would not be fun. So
is
what
it
my first step, I think, for you would be try and see if the chewables help.
okay?
And then or even chewables once a day and then try and work yourself up to twice a day and see if that works.
Thank you.
Of course.
Okay, we are at our time here. Dr. Mathai, thank you so much for another wonderful presentation, and the Q&A was absolutely spectacular. You answered everything. That was impressive. Thank you again. Folks, for those of you who maybe joined a little bit later, or you wanted to watch a replay, we will be having the replay shown a little later on this week, and we will share it with everybody. But without further ado, thank you again, Dr. Mathai, for a great presentation. And thank you again, everybody,